Hello, let's discuss common cosmetic dental procedures. The most common or easiest thing you can do is bleach the teeth if somebody wants teeth that are just a little bit lighter. These slides were taken out of my Aesthetic Restorative Dentistry book, so they're a little fluorescent. Bleaching is an interesting thing because you never know exactly what you're going to get with bleaching. And you'll think, well, that dentist really knows how to bleach teeth, or this dentist is not such a good bleacher. No, it mainly depends on your parents. We're all using basically the same technique. The degree of bleach you get depends basically on how far the yellow is into the tooth. If it's in the outer part of the tooth, those teeth are going to bleach well, and you're going to think, boy, Dr. Cutbirth really knows how to bleach teeth. If the yellow is coming from deep within the tooth, the dentin, or say you have tetracycline stain, those teeth are not going to bleach as well. So I found that all teeth bleach to some degree, but if it's deep within the tooth, the yellow's deep within the tooth, those teeth don't bleach as well. Now, what about in-office bleaching like Zoom bleaching or at-home bleaching where you use the trays? I like the trays. Why? The Zoom bleaching is so intense that if you have any gum recession, you can light those patients up. They can get hypersensitive teeth. It goes away and you give them these trays with a desensitizer to place, but they can be hypersensitive for a period of time. So if we use the in-office bleaching, we use it for about a third the amount of time recommended, just in case the patient has gum recession and root exposure, because if that intense in-office bleach gets on those roots for 30 minutes, that patient is going to be lit up. They're going to have hypersensitive teeth. I like the at-home because it takes about 5 days, 30 minutes a day, but it's not as intense as the in-office, but it gets you to exactly the same place. Then you use the trays for 30 minutes about once every 3 months. So it gets you to the same spot, but you don't have to worry much at all about the hypersensitivity, and you can regulate it yourself. So these are different cases we've bleached, and I look really good in these cases. I look like I really know how to bleach teeth. I can thank the patient's parents or their genetics for this because the yellow is in the outer part of the tooth. This former Baylor president, and the yellow is in the outer part of the tooth, and those teeth bleach well. Bonding is good for the incisal edges of teeth or the facial, if you've got a little place right there, these incisal edges of the teeth, or you've chipped anterior teeth. Now guess what? If you bond these areas like this or like this, now with bonding, the bonding cannot increase the length of the tooth more than the longest part of the existing tooth. What that means is you can't make this bonding any longer than that part of the tooth, If you do, the patient's going to grind it off. It's also imperative that these cases wear a night guard. They did this to their teeth. Believe me, they'll do it to the bonding. So if they won't wear a night guard, I'm not going to bond the incisal edges of their anterior teeth. See, I can't make the bonding any longer, or shouldn't, than the longest part of the existing tooth. I can make it this long. If I make it any longer, they're going to wear it off. Now, most people don't do the extreme grinding way out on the ends of their teeth during the day when they're awake. They do it at night when they're sleeping. You'd have to be a little crazy if you did that kind of grinding during the day. I'll show you what that looks like. Again, you ought to have these books, Dental Diagnosis and Aesthetic Restorative Dentistry. I can't practice without them because I'm a visual learner. See how this person is rubbing their teeth together. You actually sharpen your teeth like you're sharpening a knife, and you get this little wire edge on the facial of the upper teeth and the lingual or the tongue side of the lower teeth. So you have to wear a night guard. If you went with that, see, I bonded this edge, and the patient did really well for about 4 or 5 years. Then she decided she didn't need the night guard anymore. Guess what happened? Same thing. In my practice, people get a night guard when they've stopped growing. Girls when they're about 16 and guys when they're in their low 20s. And I say it's like brakes on a car. If you don't wear it, fine. go ahead. But you're like an annuity plan for my practice. My daughters got one when they were 16. My wife's had one our whole married life, because you can see how this person without a night guard has sharpened the teeth on the facial of the upper teeth and the lingual, or the inside of the lower teeth. They do that at night when they're sleeping most of the time. You'd have to be kind of have a psychological issue going on if you did all that by day. Almost everybody in our practice wears a night guard. Certainly, if you place veneers on the anterior teeth, they wear a night guard. See, but remember, with bonding, you can't make it any longer than the longest part of the existing tooth. Veneers versus full facial composite bonding. I get this question a lot. So there are a lot of dentists that like to do facial composite bonding, meaning you put composite across the facial surface, the entire facial surface of a tooth, as opposed to a veneer. I don't like that at all. The only thing that's good about it is it's less expensive than a veneer. The problem with it, in my opinion, is composite stains, it chips, it comes loose, and it does not reflect and refract light like a veneer. A veneer is porcelain or lithium disilicate, or it may be zirconium. Those materials reflect and refract light like a natural tooth. Composite absorbs light, so it looks dull and unattractive after a while. This person had had composites placed on her 4 anterior teeth. I would never do 4 teeth unless the patient liked the shade of her existing teeth. You can see she had some tetracycline stain, and so if you're going to change the shade of teeth, I'm going to place veneers back to at least the first bicuspid, and depending on how many teeth she showed when she smiled, probably back to the second bicuspid. But you can see how that composite over time has stained. I didn't place this, but she came into the office looking like this. See, it's just stained over time. So with a veneer, you have to prepare teeth. You have to remove some tooth structure. Why? Why not just stick the veneer on the teeth? If you don't want fat teeth, you've got to take something away if you put something on. I'm not a fan of no preparation veneers, because you've got to make the tooth fatter. And in my opinion, it doesn't look good. I don't like overbulked teeth. So you have to remove a little tooth structure. That's of no consequence, because you're still in enamel, and even if you placed no prep veneers, even if you placed composite versus a veneer, they're still irreversible. You can't take that stuff off. Once you bond it to the tooth, you're done. And so, in my opinion, I want to do it the very best it can be done, and there are a lot of reasons why you prepare teeth. I include the interproximal and the incisal based on the studies by Monnier and Douglas, because it makes the veneer stronger. The tooth is not weakened at all according to the studies, and you eliminate any chance of dark shine through. So we're placing veneers on these teeth, and this is as she presented with the bonded composite. That's not how it looked when it was first placed. This was done about 5 years ago, and you see how it absorbs stain. It doesn't reflect and refract light like porcelain or lithium disilicate. So these are veneers, and she had tetracycline stain on the maxillary and the mandibular teeth. We placed crowns on the posterior teeth to replace these. We had some issues with those. So they're veneers back to the second bicuspid, because she had a big smile line. So we've got veneers on the lower anterior teeth, crowns on the back teeth, because we had some issues there. And it's just a much more aesthetic restoration. So I don't do full facial composites at all. It's a difficult procedure. It's hard to get it right. And once the patient leaves the office, almost immediately, you've got to worry about chipping, fracture, and staining with full facial composites. With veneering, it's just much more aesthetic. So I don't do, and I also don't do no prep veneers for the reasons I talked about. I don't like fat teeth. And when these first came out, probably 20 some odd years ago, I can't even remember when it was, I went to a couple of seminars in Dallas, and the speaker was showing the final results, and I thought those looked like horse teeth. They looked like giant teeth, and it just wasn't aesthetic for me. So I've never done no prep veneers. No prep veneers means you don't take anything away, but you put the veneer on the facial surface of the teeth. And also, I like to prepare interproximally between the teeth and the incisal edge because the veneer is much more stable. You don't have to worry about dark shine through if the teeth have tetracycline stain. Plus, if the patient drank red wine or a lot of coffee, you don't have to worry about that little stain in between the teeth. That's another thing I encourage patients to do in my practice, is to help themselves. Don't put it all on me. As I've said before, the only thing that lasts forever, almost no matter what you do to it, is a shot put and a flint rock. Anything we do in dentistry, a patient can destroy if they try hard enough. So if you don't care if you drink red wine, white wine, or vodka, drink vodka and white wine because it doesn't stain your teeth. If it stains carpet, it can stain teeth. Now, veneers don't stain, but there has to be a little place all around the margins where there's just a tiny little micro gap filled with composite, and composite can stain. So I'd go with the white wine and the vodka over the red wine, and I wouldn't drink real strong coffee, or maybe a cup in the morning, but don't drink it all day long. These are some more facial composites that somebody had placed on the teeth. Again, I didn't do it because I don't do facial composite, but you can see how they stain, they chip, they absorb stain, and they absorb light. They don't reflect and refract it. So these are full facial composite. I'm not saying don't do it. The advantage is they're less expensive than veneers. So if that's what you're looking for, it may be worth it just to make your teeth look better, but don't look at full facial composites to be something that's long-lived or without maintenance, or to look as good as a porcelain or a lithium disilicate veneer. So these are the full facial composites. It's hard in between the teeth. This interproximal part has not been prepared, so you tend to accumulate plaque and food debris and stain. So these are the full veneers. We've not done the lower anterior teeth. All we did was bond the incisal edges of the chip teeth. Now, I don't pay any attention to the shade of the mandibular teeth if I'm veneering maxillary anterior teeth. Why? Because you can see these mandibular anterior teeth are dark. The reason I don't is because if I match these teeth, this tooth shade, that patient is not going to be happy, because everybody wants a lighter smile. See how dark those teeth are. So I've made these the ideal shade, because when you smile, generally, and that's when we take photographs, generally you don't see the mandibular teeth. You just see maybe the incisal 1/4 of those teeth. The other reason is most of our patients that have the maxillary anterior teeth veneered come back and have the mandibular anterior teeth veneered at some point. So it's like wallpaper in your room, and you've got something wrong with the wallpaper over here, so you replace that wallpaper to match this wall and that wall and that wall. Well, about a year later, something goes wrong with this wall, and you got to replace that wallpaper to match those. You see how it goes. And about this wall, the woman says, you know, I've never liked the shade of that wallpaper. So you would have been much better off when you replace this one, if you'd had a treatment plan, to replace it all to the style that she liked. So if something ever happened to the other, or just it looks the way she wants it to look, don't fix one little thing just and assume something. In this case, if I'm veneering the maxillary anterior teeth and I'm doing enough teeth that I can change the shade, I'm going to make that the ideal shade and not worry about the shade of the mandibular anterior teeth. I'm probably going to bleach those teeth if we're not doing them at the same time, but I'm not going to try to match the shade of the mandibular anterior teeth. That's why if the person is not happy with her teeth, let's take this tooth, this person. If she didn't like the way these teeth looked or the shade of these teeth, you can't do 2 or 4 teeth, because if you do 2 or 4 teeth, you've got to come close to matching the shade of the adjacent teeth. If you're going to lighten the shade, change the shade, you've got to go back to the first bicuspid or the second bicuspid and take photographs of the posterior teeth from this angle with your camera so the patient can see how many teeth show. If he or she is discriminating, there's nothing worse than somebody that has 6 veneers on their 6 anterior teeth, and these teeth look like that. So anybody looking at the side can see they look fake. It looks awful. So I won't do that because it's not just about the patient, it's also about me, and I don't want my work out there looking bad. And that would not be a good result. So I treatment plan it, and I tell the patient why I'm recommending what I recommend. So that's the dental minute. These techniques work, and they work every time.